Telerehabilitation in India points to ponder. Abstract. Inaccessibility, dependency on caregivers, and healthcare costs are challenges faced by the geriatric population in low and middle income countries. Due to these factors, elders are unwilling to engage in rehabilitation and preventive health programs. Therefore, there is a need to identify alternative methods of health promotion services, and telerehabilitation is one such method. Hence, this pilot study aimed to identify the barriers to video conferencing, which is an easy method of telerehabilitation delivery. This study was a cross-sectional survey using interview and observation methods. The result suggested that training on using technology is essential. This study was done in a limited urban area and participants were educated and computer literate. It is anticipated that other populations may vary in their perceptions and hence further research is required. Establishment of prerequisites prior to actual delivery of telerehabilitation may potentially increase acceptability and hence sustainability. Introduction. Technological advancement in healthcare has increased life expectancy, thereby increasing the number of people over the age of 60 years. One of the problems with this increase in the number of elders is the challenges posed to the healthcare system of the country. Data shows that elderly dependency would increase from 13.1 in 2001 to 27.9 in 2051, which may bring about greater medical, economic, and social challenges, increasing the utilization of rehabilitation services. Inaccessibility, increased dependency on caregivers, and the cost of health care among geriatric population are the most important challenge that low and middle income countries including India are facing today. In India, currently disability prevention and health promotion programs are not covered by insurance and so clients have to bear the cost themselves. Due to this factor, most elders are unwilling to engage in preventive health programs and health promotion activities in formal setting which they perceive as an unnecessary economic burden. Therefore, there is a need to identify alternative methods of rehabilitation and health promotion services. One such method, described extensively in literature, is telemedicine and its counterpart, telerehabilitation. Telerehabilitation is different from telemedicine in the fact that it requires repeated, routine, and frequent interaction with a therapist along with complete visualization of the client. Many of the exercises are done in standing, and alignment of various joints starting from the ankle to neck needs to be visualized, whereas telemedicine is often a consultation and the need for visualization is often a small localized part of the body. Although there have been several articles published in India on various methods of telerehabilitation and efforts have been made by NGOs and government agencies, none of these have been sustainable. Hence, the objective of the study is to identify the reasons that elders may perceive as barriers during telerehabilitation via video conferencing. Pilot study was a cross-sectional survey using informal interview and observation of elders living independently in the community. From the Institutional Ethical Committee was obtained and 20 individuals over 60 years having accessibility to a computer with internet connection with adequate cognition who could understand and read English and follow commands for computer usage and exercise were invited to take part in the study through convenient sampling and awareness lectures. Elderly having visual, auditory, and balance impairments and who were not independent of the basic activities of daily living and unable to understand the procedure were excluded. Informed consent was obtained from 11 participants. Repeated video conferencing sessions were conducted to optimize distance, furniture characteristics, bandwidth, and lighting considering the 5th and 95th percentile of the population selected. Using Google Hangout, a real-time face-to-face interactive session was carried out in the presence of a physiotherapist at their residence. A set of exercises were delivered to the participants in the form of demonstration through video conferencing, where the therapist and the participants were able to observe each other. An observational method was used to obtain information regarding furniture, size of laptop, and a room size at individual residences of the participants. Interview was carried out following the telerehabilitation sessions to understand the elders' views on telephysiotherapy through video conferencing, the challenges encountered, and the overall experience of the procedure. Data were analyzed using descriptive statistics. Who had spacious homes were selected at first for the delivery of telerehabilitation. Using available resources, video conferencing was conducted and optimization of viewing distance based on other characteristics was ascertained. The height of the participants varied from 4'11" to 6'1", and the table height ranged from 17 to 30, and screen size of 14 inches, and angle of the laptop screen to keyboard ranged between 85° to 90°. Ideal viewing was achieved at 15.5 feet between the tips of the toes to the camera. Using the optimum dimension and available resources, the procedure was replicated on 8 participants. Video conferencing was conducted and optimization of viewing distance based on other characteristics was ascertained. The observations revealed that the participants used both laptop and desktop with screen size ranging from 13 inches to 20 inches. The chair height ranged from 15 to 19 inches, and table height ranged from 13 to 43, and the distance from the screen to person ranged between 7 to 13 inches, with an angle of camera ranged between 80 to 100 degrees. For optimum viewing of the participant, several factors must be manipulated. Hence, this would be difficult to apply to this cohort for various reasons as depicted in Table 1 below. During the teleconferencing, several technical issues were encountered. On debriefing the elders through in-depth interview, it emerged that they were unaware of the potential benefits of the program and hence were reluctant to invest time and energy to adhere to instructions and standardizations. To complete her study and did not perceive any benefits for themselves. Moreover, health promotion and illness prevention through active modes like exercise and food are only recently becoming popular. Traditionalists are still steeped in the treatment of illness rather than health promotion. Another factor is that the client's perception of exercise is equated to yoga and or walking. Discussion and reflection. The results and opinion from the participants of the present study suggest that training for both therapist and client on using the telerehabilitation method prior to actual delivery of the program is essential. In addition, an expert in the computer needs to be a part of the team for troubleshooting. The minimum bandwidth required is 2 Mbps for video conferencing for one location. The source of light should be opposite to the person with a minimum power of 80 watts or bring sunlight, and adding an external mic would be beneficial. Furthermore, the instructions should be clear with good enunciation and at slow speed and single step commands. It is better if they work in a group as there is a spirit of competition and hence better adherence to therapy. This is a pilot study done in a limited urban area and participants were educated and computer literate. It is anticipated that and hence further research is required. Establishment of prerequisites prior to actual delivery of telerehabilitation may potentially increase acceptability and hence sustainability. These would be future objectives. Conflict of interest. The author received no financial support for the research, authorship, and or publication of this article.